Good morning, class. So today we're going to be going over Chapter 15, Respiratory Emergencies. So medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Respiratory, anatomy, signs, symptoms, and management of respiratory emergencies, including those that affect the upper airway and the lower airway. So what structure in the human body separates the upper and the lower airway? The larynx, correct? So anatomy, physiology, pathophysiology, assessment and management of epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, COPD or chronic obstructive pulmonary disease. Okay, environmental industrial exposure, toxic gas, pertussis or whooping cough, cystic fibrosis, and pulmonary embolism. Pneumonia, viral respiratory infections. So patients often complain of dyspnea. If you guys break dyspnea down again, it's DYS means difficulty, and then the NEA means breathing, so difficulty breathing, shortness of breath or difficulty breathing. Can be caused by many different conditions. Cause can be difficult to determine. Anatomy of the respiratory system. Respiratory system includes all the structures that contribute to breathing: diaphragm, chest wall muscles, accessory muscles of breathing, nerves to the muscles. Upper airway consists of structures above the vocal cords: nose and mouth, or pharynx, oropharynx, or nasopharynx, jaw, oral cavity, pharynx, larynx. So here we have structures of the upper airway: the pharynx, mouth or oropharynx, epiglottitis, back here. It's going to be a leaf-shaped structure to protect the windpipe, to make sure nothing gets down into the lungs. And the separation between the upper and lower airway is going to be the larynx. Down below you have the trachea or windpipe. Bronchioles branch off the main bronchi, left and right. So main bronchi, and then you're going to be bronchioles right here. And that's part of your lower airway. And then you also have your pulmonary capillaries and your alveoli. Principal function of lungs is respiration, exchange of oxygen and carbon dioxide. Air travels through trachea into lungs to bronchi, your larger airways, bronchioles, smaller airways, and alveoli, where actual exchange takes place. So physiology respiration process includes inspiration, expiration. Oxygen is provided to the blood, carbon dioxide is removed, takes place rapidly at level of alveoli. So remember how blood moves through the heart. Deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and arterioles. Gas exchange takes place at the capillaries covering the alveoli. And then oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules. So blood comes on the right side of the heart and then goes into the lungs and then goes back into the left side of the heart. And the left side pumps out the oxygenated blood to the rest of the body. In the alveoli, oxygen passes into capillaries, carbon dioxide returns to the lungs. Brainstem senses blood's carbon dioxide levels, regulates breathing rate and depth. Oxygen exchange can be hindered by conditions in the anatomy of the airway, disease processes, traumatic conditions, abnormalities in pulmonary vessels. Recognize the signs and symptoms of inadequate breathing and know what to do about it. Some patients have chronic carbon dioxide retention. Use caution when administering oxygen. So people with COPD would have chronic carbon dioxide retention. Cause of dyspnea. Patients often have dyspnea or hypoxia with pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental industrial exposure, and drug overdose. Dyspneic patients may have gas exchange obstructed, damaged alveoli, obstructed air passages, obstructed blood flow to the lungs, excess fluid in pleural space. So if you look at table 15-.2, signs and symptoms of inadequate breathing. Patient reports difficulty breathing. Altered mental status associated with shallow or slow breathing. Patient appears anxious or restlessness. Pediatric patient appears sleepy or listless. So this is a very important one to remember. A baby that's crying has a good airway. A pediatric patient that's quiet is a bad sign. Okay, respiratory rate is too fast or too slow. Breathing rhythm is irregular. Skin is pale, cool, clammy, or cyanotic. And then breath sounds: wheezing, gurgling, snoring, crowing, stridor, harsh, high-pitched barking sounds. And decreased or noisy breath sounds are heard on one or both sides of the chest. Patients may also complain of chest tightness or air hunger, common with cardiopulmonary diseases. Pain can cause rapid, shallow breathing. Breathing deeply causes pain because the chest wall expands. Upper or lower airway infection. Infectious diseases may affect all parts of the airway. Some form of obstruction causes dyspnea, mucus and secretions obstructing airflow in major passages. So someone who's sick, has a cold, is coughing up mucus, or has a stuffed nose, is something caused dyspnea. Swelling of soft tissues in upper airways, impaired exchange of gases in the alveoli. So people with COPD or CHF can have problems, or exacerbation as we call it sometimes in the field. And this hinders exchanges of gases in the alveoli. So Croup's a common one in pediatric patients. Inflammation and swelling of pharynx, larynx, and trachea, stridor and seal bark cough. Responds well to humidified oxygen. So this is a telltale sign of a patient with croup. You're going to hear what's called a seal bark cough. So they sound almost like a seal when they're coughing. And they may have croup. Sorry, class. So, and this is just a picture of croup in a pediatric. They're going to have a swollen pharynx, swollen larynx, swollen trachea. So, it's going to be hard. See how the airway kind of constricts a little bit, or gets constricted because of the swelling, and it's going to get hard. It's going to be hard for them to get air in or out. So epiglottitis, bacterial infection causing inflammation in epiglottitis. Children are often found in tripod position and drooling. Position comfortably and provide oxygen. So here we have another picture. There's swollen epiglottitis, the narrow airway. So for pediatrics who have epiglottitis, a good sign is a patient is drooling and they're unable to get air. And for these patients, we normally don't really touch. We don't want to deteriorate their condition in any way. We're going to take them to the hospital as soon as we can, because as EMTs, you're not going to be able to really do anything for this pediatric patient. They're going to need a doctor. So respiratory syncytial virus, or RSV, common cause of illness in young children, causes infection in the lungs and passages. Look for signs of dehydration. Treat airway and breathing problems. Humidified oxygen is helpful. Bronchiolitis, viral illness often caused by RSV, usually affects newborns and toddlers. Bronchioles become inflamed, swell, and fill with mucus. Pneumonia, bacterial pneumonia will come on quickly and result in high fever. Viral pneumonia presents more gradually and is less severe. Especially affects people who are chronically ill. Assess temperature and provide airway support and supplemental oxygen. Pertussis, or whooping cough, airborne bacterial infection that mostly affects children under 6. Patients will be feverish and exhibit a whoop sound after a coughing attack. Watch for dehydration and suction as needed. Influenza Type A, become pandemic in 2009. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. May lead to pneumonia or dehydration. Tuberculosis, TB. I'm sure you guys have all been tested for this. Bacterial infection that most often affects the lungs can remain inactive for years. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. Wear gloves, eye protection, and an N95 respirator at a minimum. So remember these symptoms for anybody who's complaining of this, and be vigilant in your PPE. Make sure wear gloves, eye protection, N95 respirator. Also put a respirator on the patient, and then turn on the air vent in the back. Turn on the AC or the heater to get air flow moving in the back when you're with the patient. Acute pulmonary edema. Heart muscle can't circulate blood properly. Fluid builds up within alveoli and in lung tissue. Referred to as pulmonary edema. Usually results of congestive heart failure, or CHF. Most patients have a long-standing history of chronic congestive heart failure. So chronic obstructive pulmonary disease, or COPD, slow process of dilation and disruption of airways and alveoli, caused by chronic bronchial obstruction, may be the result of lung and airway damage from infection or inhalation of toxic gases. Tobacco smoke can create chronic bronchitis. Emphysema is the most common type of COPD. Loss of elastic material in the lungs. Causes include inflamed airways, smoking. Most patients with COPD have elements of both chronic bronchitis and emphysema. So, in this picture we have our normal lung, alveolus, and bronchial. So inflamed lung or obstructed lung, the air is going to be trapped down here, and you have inflammation or infection, and also build up of mucus. And this is going to be obstructed lung, your obstruction and your infection. So see how much air you're going to be able to get in through here, and then once it becomes inflamed, the airway narrows a little bit. It's going to be a little harder to get air into. And once that builds up and closes off, it's a serious condition. Patients with pulmonary edema will have wet lung sounds. So what we call them in the field are rails. Rails are wet. Patients with COPD will have dry lung sounds. Can be easily confused with CHF or congestive heart failure. Asthma, hay fever, and anaphylaxis, result of allergic reaction to inhaled, ingested, or injected substance. In some cases, allergen cannot be identified. In some cases, there is no identifiable allergen. Asthma is acute spasm of smaller air passages, bronchioles. So normal, you got a lot of room to get air in. Narrowed, you have mucus obstructing bronchial. So it's building up, it's closing off that airway slowly. Asthma affects all ages, most prevalent in children 5 through 17 years. Produces characteristic wheezing. So this is what you're going to hear in your lung sounds when you guys check. Remember, both upper and lower, both front and back. Asthma attack may be caused by allergic reaction to foods or allergens, or severe emotional distress, exercise, and respiratory infections. Hay fever causes cold-like symptoms. Allergens include pollen, dust mites, pet dander. Anaphylactic reaction can produce severe airway swelling. Total obstruction is possible. Treat with epinephrine, oxygen, and antihistamines, or Benadryl. Spontaneous pneumothorax. Pneumothorax is accumulation of air in pleural space, most often caused by trauma. May be caused by medical conditions. Spontaneous pneumothorax. Occurs with lung infections or in weak lungs. Patient becomes dyspneic. Breath sounds may be absent or on affected side. So here we have a collapsed lung on this side. So you're probably going to get some what we call a seesaw breathing. So one side of the chest is going to rise, the other is going to stay flat. And you're going to hear absent lung sounds on one side. So pleural effusion, collection of fluid outside the lung, compresses lung and causes dyspnea. So what happens is it builds up in the pleural space and it pushes down on the lung. And it narrows the lung airway or the lung passageway, and it causes shortness of breath. It can stem from irritation, infection, congestive heart failure, or cancer. Upright position eases pain. Obstruction of the airway. Patient with dyspnea may have mechanical obstruction. Treat quickly. In unconscious patients, obstruction may be caused by aspiration of vomitus or tongue blocking the airway. If patient was eating just before dyspnea, always consider foreign body obstruction. So here we have food including upper airway, so it's down here. And then you got your air passes, so just right below the epiglottitis. And then you have tongue, including upper airway. Okay? So when a patient's unconscious and they're laying supine, normally the tongue falls back. And then it occludes the airway. So that's why we put an OPA in people when we start to bag them. It holds the tongue in place and it opens the airway back here. So we go ahead and get good compliance with our BBM. Pulmonary embolism, blood clot that circulates through the venous system. Circulation cut off partially or completely significantly decreases blood flow. If large enough, can cause death. Signs and symptoms include dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, hemoptysis. So this happens a lot when older people are on planes for a very long time. They don't get enough blood circulation. They're sitting down for long periods of time, especially long flights. Blood pools in the lower legs and it begins to clot. And once they stand up, that clot could break loose and travel all the way to the heart. We call it the PE, or pulmonary embolism. So hyperventilation, overbreathing to the point that arterial carbon dioxide falls below normal. May be indicator of life-threatening illness. Body may be trying to compensate for acidosis. Buildup of excess acid in blood or body tissues can result in alkalosis. Buildup of excess base in body fluids. Cause symptoms of panic attack, anxiety, dizziness, numbness, tingling, or painful spasms of the hands or feet. So this is another telltale sign of people who are having an anxiety attack. They're having spasms and they can't feel their hands or feet because they're blowing off too much CO2. So their hands are going to start cramping. So environmental and industrial exposure. Pesticides, cleaning solutions, chemicals, chlorine, and other gases can be released. Carbon monoxide, odorless, highly poisonous, produced by fuel burning appliances and smoke. Do not put yourself at risk. Scene size up. Remember, every call, scene safety, use standard precautions of PPE. Consider possibility of infectious disease or toxic substance. Mechanism, injury, nature of illness. If in question, ask why 911 was activated. We do get a lot of calls for unknown medical problems. While en route, we could ask, do we have an update? Do we have a mechanism? So we kind of know what we're going into. Question the patient, family, and or bystander to determine NOI, or nature of illness. Primary assessment. Identify immediate life threats. What are you walking into? What's nearby? What could present a danger to you and your partner? Form a general impression. Note age and position of patient. So when you're walking in, you're always looking at the patient. You're seeing ABPU. Use ABPU skill. Is a patient alert? Is a patient only alert to verbal stimuli? Is a patient alert to painful stimuli? Or is a patient unresponsive? Ask patient about chief complaint. Ask him why you got called. Just because you got dispatched to abdominal pain, don't start asking him questions about his abdomen. Ask the patient why he called. to confirm that maybe he did call about abdominal pain. Airway and breathing. Make sure airway is patent and adequate. Assess rate, rhythm, and quality. Ask the following questions. Is the air going in? Does the chest rise and fall with each breath? Is the rate adequate for the victim's age? So these are questions you're going to be asking in your own head. And also when you guys are doing your skill assessment, at the end of the year, assess rate, rhythm, and quality. What's the patient's breathing? What's his rate? Is it within normal limits? Is the rhythm regular? Is it irregular? And what's the quality of it? Is it shallow? Are you guys going to have to give him oxygen? Are you guys going to have to bag? Is it within normal limits? Or is it fast? Assess breath sounds. Check breath sounds on the right and left sides of the chest. Abnormal sounds include wheezing, rales, rhonchi, and stridor. So wheezing's going to be in your upper lungs, most likely. Rales, the best way to hear rales is going to be down at the bottom, the bases, especially in the back. Rhonchi is going to be mucus, so probably going to be the upper lungs. Stridor is another upper airway disease. So these are where you guys are going to be checking lung sounds on every patient, no matter what. So you're going to be listening to lung sounds on both sides, and then you're going to go to the back. Listen to lung sounds on both sides again. Make sure you guys don't miss anything. Don't just check lung sounds up here and then call it done, because you might have wheezing in the front. You might have wheezing down below. Just because it's clear up here doesn't mean it's going to be clear down here, or vice versa. Circulation. Evaluate for shock and bleeding. Assess capillary refill in infants and children. Assess perfusion by evaluating skin color, temperature, and condition. Reassess life threats. So reassess ABCs. Reassess any major interventions that you guys have done. If you guys put on a tourniquet for a trauma patient, make sure the patient's bleeding has stopped. Make sure that tourniquet is still tight. Transport decision. Condition is unstable and there is a possible life threat. Address the life threat. Proceed with rapid transport. So when you guys make a transport decision, the patient is unstable. Try and stabilize the life threat and then get going. So make it a code 3 transport. Lights and sirens. History taking. Investigate chief complaint. Objective and subjective observations. Report pertinent negatives. So what does objective mean? Objective is what you can see. Does a patient look cyanotic? Is a patient diaphoretic? Is a patient sweating? And then subjective. What is the patient telling you? Are they telling you that they're having shortness of breath? Are they telling you they have chest pain? Find out what the patient has done for the breathing problem. Some patients who have breathing issues such as asthma or COPD, they may already have a pre-prescribed medical medication for them, like albuterol, like breathing treatments. Or they might already have oxygen. They might have turned up their oxygen. Instead of 2 liters that they're normally on, they're going to be on 4 liters. See if that's helped. Go ahead and get your sample history. Signs and symptoms, allergies, meds, past history, last time they ate or drank anything, and events leading up to the problem. What were they doing when it started? Did it come on suddenly? Did it come on slowly? OPQ-RST assessment. Onset, provocation, palliation, quality, radiation, region, severity. And the PACE assessment. You're going to use PACE on every patient who's complaining of difficulty breathing or any breathing problem. So specific for patients with dyspnea. Progression. Okay? So this is another one. Progression. How did it come on? Did it come on suddenly? Did it come on slowly? Did it build up over time? And are they having any chest pain with it? Sputum. Are they coughing anything up? That'll tell you if they're sick or if they're just getting over an illness. Are they coughing up any mucus and talking tiredness? When you're asking them questions, are they talking in full sentences? Or are they talking in 2 to 3 word sentences? Are they having trouble getting air out after a couple sentences or a couple words? And then exercise tolerance. Are they normally able to walk up the stairs? Are they normally able to walk 10 feet to the kitchen? And are they able to do it right now? Because I would tell you something else going on. If the patient's normally able to walk up the stairs with no issues, but then they can't even take 5 steps up the stairs, that's a problem right there. Secondary assessment, more in-depth assessment of body systems. So respiratory, cardiovascular, skin, blood pressure, neurologic. So after you've done your ABCs, you've gotten your chief complaint, you've asked your PACE questions, your PQRS, T questions. Based on what you think the patient's complaining of, or what you may think the medical problem is, you're going to do your in-depth assessment. If you think it's a respiratory problem, you're going to do a respiratory assessment. If you think it's a cardiovascular assessment or heart problem, you're going to do cardiovascular assessment. Okay. Sometimes people have both respiratory and cardiovascular problems, and you're going to have to do both assessments and then proceed only after addressing life threats. Look for signs of COPD. Patients older than 50 years of age, history of lung problems, active or former cigarette smoker, tightness in chest, constant fatigue, barrel-like appearance to chest, use of accessory muscles, abnormal breath sounds. So with people with COPD, they're normally prescribed oxygen when you're walking into their residence, or you're walking into wherever they might be. Some people might have a fanny pack with a little O2 bottle with them, or they might have O2 bottles at home. So when you're walking in, that's something else to look for, and it'll probably give you a good indication that the patient does have COPD or some kind of breathing problem. And then ask also if they smoked today, or if they were a smoker. And then also ask if they took a breathing treatment, if they have one, and ask if that helped. Sometimes patients with COPD who are having difficulty breathing take a few breathing treatments either a day, or they take them right when they're having difficulty breathing. And if that didn't help, they might need some more medication or some steroids to help open those lungs up. So reassessment, repeat the primary assessment, assess for changes in condition. So after you do your full assessment, you're repeating everything you do. You're going to repeat your ABCs, you're going to repeat your vital signs. You're going to repeat your physical assessment. You want to make sure that patient is doing better, or you want to see if the patient is deteriorating. If you have to change your interventions. Interventions may include oxygen via non-rebreathing mask at 15 liters a minute, positive pressure ventilations or bag valve ventilations, airway management techniques, positioning in high Fowler's position or position of choice, assisting with respiratory medications. So most patients with breathing issues, they're not going to be able to lie flat. You're going to want to keep them upright. It's going to help get a little more airflow to their lungs. And then assist with any respiratory medications that they have. Do they have any breathing treatments? Do they have any inhalers? Emergency medical care. Administer supplemental oxygen. Some patients may need CPAP or BVM. Patients may have a metered dose inhaler or MDI or small volume nebulizer. Consult medical control and make sure medication is indicated. So know your online and offline protocols. Are you guys allowed to help out with MDIs? Or do you have to call a doctor and ask them for permission? Contraindications. Patient unable to coordinate inhalation, inhaler not prescribed to patient. So this is another big one. Do not let a patient take anything that is not prescribed to them. If there's medication on scene, say if their sister has asthma, and they want to take their sister's inhaler, do not let them take it. Permission not obtained from medical control. Medical control says no, or your protocols do not allow it. Do not give them any Medications, not permissible by local protocol. So is it within your protocol to help out with those medications? Maximum prescribed dose already reached. Medication has expired. Other contraindications specific to medicine. So if they've already taken their maximum prescribed dose, or if you've already given them maximum prescribed dose, do not give them any more. So most medications are used to relax the muscles that surround the air passages in the lungs. Common side effects of inhalers: increased pulse rate, nervousness, muscle tremors. Treatment of specific conditions: upper or lower airway infection. Administer humidified oxygen if available. Do not attempt to suction the airway or place in oropharyngeal airway, or OPA. Position comfortably. Transport promptly. Acute pulmonary edema. Provide 100% oxygen. Suction if necessary. Position comfortably. Provide CPAP if indicated and allowed by protocol. Transport promptly. So a good way to intervene for patients with acute pulmonary edema, or CHF, is CPAP. Pushes the fluid back out. Opens the airway a little bit. Chronic obstructive pulmonary disease. Assist with prescribed inhaler. Watch for side effects from overuse. Position comfortably. Transport promptly. Asthma. Be prepared to suction. Assist patient with prescribed inhaler. Provide aggressive airway management, oxygen, and prompt transport. A prolonged asthma attack that is unrelieved may progress into an emergency known as status asthmaticus. This is a serious condition, so be aware. If their inhaler is not working and they've taken the maximum prescribed dose, and you've already helped them out with what's your maximum prescribed dose per your local protocols, that this may be a serious condition the patients experience. Hay fever, unlikely to need emergency treatment. Anaphylaxis, remove the offending agent. So if a patient gets stung by a bee, you want to get the stinger out. An easy way to do that is to grab a credit card and go slightly over the skin, dragging the stinger. That way you pull everything out. Maintain the airway. Transport rapidly. Administer epi. Spontaneous pneumothorax. Provide supplemental oxygen. Transport promptly. Monitor carefully. Pleural effusion. Fluid removal must be done in hospital. Provide oxygen. Transport promptly. Obstruction of airway. Partial obstruction. Provide supplemental oxygen and transport. Complete obstruction. Clear obstruction and administer oxygen. Transport rapidly to emergency department. So if patient is having a partial obstruction and they're coughing, but their airway is intact, let them cough. Let them get the obstruction out on their own. If the patient's having a severe airway obstruction and it doesn't look like they're moving air, they're not breathing adequately, you're going to have to step in and intervene. Possibly a Heimlich maneuver, or see if you could open the airway and pull the obstruction out. Pulmonary embolism. Supplemental oxygen is mandatory. Position comfortably. If hemoptysis is present, clear airway immediately. Transport promptly. So this means coughing up blood. So you want to make sure to suction or clear the airway so a patient doesn't aspirate and get in their lungs. Hyperventilation. Complete primary assessment and gather history. Do not have patient breathe into paper bag. Reassure the patient and provide supplemental oxygen. Transport promptly. So this is a big one. Do not have patient breathe into paper bag. We don't do this anymore. Patient's going to rebreathe that same CO2 that they're blowing off, and that's going to cause them to pass out. Environmental industrial exposure. Ensure patients are decontaminated. Make sure patients are decontaminated before you get to the hospital. Because as soon as you bring that patient into the ER, they're going to have to decontaminate the whole ER. Hospital's not going to be very happy with you. and the doctors aren't going to be very happy with you. Treat with oxygen, adjuncts, and suction based on presentation. Make sure you let the hospital know what they were exposed to. Bring any labels or containers that the patient might be exposed to into the hospital so the doctor has a chance to look at it. Okay, so foreign body aspiration, clear the airway, provide oxygen and transport. Tracheostomy dysfunction, position comfortably, suction to clear obstruction, provide oxygen. So if you guys suction a tracheostomy, make sure you guys wear eye protection. There's probably a lot of mucus, fluids in that tracheostomy. Asthma, provide blow-by oxygen. Use MDIs or metered dose inhalers. Cystic fibrosis, genetic disorder that affects the lungs and digestive system. Suction and oxygenate as needed. So review, the process in which oxygen and carbon dioxide are exchanged in the lungs is called A. Respiration is defined as the exchange of gases between the body and its environment. The exchange of oxygen and carbon dioxide in the lungs is called pulmonary external respiration. The exchange of oxygen and carbon dioxide at the cellular level is called cellular internal respiration. So remember, ventilation is the exchange of air between the lungs and the environment. It's the physical act of moving air into and out of the lungs. Okay, metabolism, series of processes by which food is converted into the energy and products needed to sustain life. Inhalation is the active muscular part of breathing. Which of the following respiratory disease causes obstruction of the lower airway? So what's the structure that separates the upper and lower airway? B. Asthma is a lower airway disease that causes the bronchioles in the lungs to constrict, or bronchospasm, resulting in various degrees of obstruction. Croup, epiglottitis, and laryngitis causes swelling, inflammation, and varying degrees of obstruction of the upper airway. So remember, epiglottitis, it's above the larynx. Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? Which of these diseases would you need to put on N95? When would you put an N95 on a patient for this too? When are you going to put on the air vent in the back to make sure airflow is moving in the back of the ambulance? So A, tuberculosis is a bacterial infection spread by cough. It is dangerous because many strains are resistant to antibiotics. And this is why you guys get tested for TB every year when you start working in the field. I have to get tested for TB every day, or excuse me, not every day, every year. Once a year we have to get tested. All the following are causes of acute dyspnea except So what does acute mean? Acute is sudden onset. Okay, so B, emphysema, form of COPD, is a chronic respiratory disease. It even says it in the disease, chronic obstructive pulmonary disease. Therefore, it presents with progressively worsening dyspnea. Asthma, pulmonary embolism, and pneumothorax are all acute conditions. Therefore, they typically present with an acute onset of dyspnea. Bronchospasm most often associated with So it tells you right in here. Spasming of the bronchioles are asthma, reactive airway disease caused by bronchospasms, sustained constriction of the bronchioles. Common triggers to an acute asthma attack include environmental allergens, stress, and temperature changes. So bronchitis is the inflammation of the mucous membrane and the bronchial tubes of the lungs. A sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite supplemental oxygen is most consistent with with these first two symptoms are going to be another hallmark sign of this process. A sudden onset of difficulty breathing, sharp chest pain, usually pinpoint chest pain, is going to be what? C. Signs of an acute pulmonary embolism, including a sudden onset of difficulty breathing, sharp pleuritic chest pain, and cyanosis that persists despite the administration of high flow oxygen. Patients who are immobile for prolonged periods of time, e.g. confined to a hospital bed, are prone to pulmonary embolism. Or remember I talked about people who are in plane rides for a very long time and they're sitting down for long periods of time, blood pools in their lower extremities, and it could end up clotting. And once they stand up, that clot could bust loose and travel up to their heart. Albuterol, beta-2 agonist, is a generic name for what does beta-2 work on? Remember, you have your alpha-1 receptors and your beta-2 receptors. So D, albuterol is a generic name for Ventolin or Proventil. Albuterol is a beta agonist which dilates the bronchioles and is commonly used to treat patients with asthma and other reactive airway diseases. An acute bacterial infection that results in swelling of the flap that covers the larynx during swallowing is called. So what structure is in the back of your airway? What does it cover? What is it? It covers your trachea, right? It's a little leaf-shaped structure. So C, epiglottitis, potentially life-threatening illness, is an acute bacterial infection that causes swelling of the epiglottis, the flap that covers the larynx during swallowing. It is characterized by a sudden onset of high fever, difficulty breathing, stridor, drooling, and varying degrees of hypoxemia. So this mostly affects infants and children. Be very careful with children when you handle them. Allow them to remain with mom and dad. If the parents are telling you the patient has a high fever and they look like they're having difficulty breathing and also they're drooling, that's going to be epiglottitis. Patient needs to get to the hospital right away. I wouldn't even try to take vital signs on the patient. I would just get him to the hospital as soon as we can and let him know what we have so the doctor could look at him and give him some medication. This is a life-threatening illness, so be aware of that. A 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when lying flat. He is coughing up pink, frothy secretions. The patient is most likely experiencing So B, as a result of his recent heart attack, the left side of this patient's heart has been severely damaged. The left side of the heart is responsible for pumping oxygenated blood to the rest of the body. When it fails to do this, blood backs up into the lungs, resulting in pulmonary edema. Signs of pulmonary edema include dyspnea, especially when lying flat. rapid and shallow respirations, and in severe cases, coughing up pink, frothy sputum. So some people also can't lie flat. They'll have pillows underneath them while they're sleeping because of the pulmonary edema, because the blood at the bottom of the lungs pulls up to the top when they're sleeping. It causes the shortness of breath or difficulty breathing. So when a patient has a right heart failure, it causes a backup of blood into the systemic circulatory system, typically causes symptoms of peripheral edema in the hands and feet. So this is why I tell you guys to check patients' legs or feet when you're dealing with patients who are complaining of chest pain, or they tell you that they have a history of CHF. Which of the following patients is breathing adequately? So remember, when you're taking the NREMT or you're taking any test, what are the key words you're going to look for when you're having a breathing patient? So when somebody tells you that they have cyanosis around the lips and irregular respirations, they're not getting adequate air. When they're telling you they have labored respirations and pale skin, that's not adequate breathing, especially at a rate of 28 breaths a minute for a 22-year-old. Normal rate is going to be 12 to 20. And then a person who has rapid and shallow respirations, that is inadequate breathing. So B, adequate breathing in an adult is characterized by a respiratory rate between 12 and 20 breaths a minute. Good chest rise indicates adequate tidal volume, unlabored breathing effort, non-altered mental status, and good perfusion of the skin, i.e. pink, warm, dry.